Welcome class. Today we are looking at our first case history. So a 45 years old male presenting with classical symptoms, that is increased thirst, frequent urination, increased appetite and a non-healing foot ulcer. Now look at his lab results. So fasting blood glucose is 150 milligram per deciliter, normal is less than 110. 2 hours post lunch blood glucose is 260 milligram per deciliter, normal is less than 140. So urine glucose is positive at 2 hours. Ketone bodies are negative. So look at these lab values and answer. So what condition is this patient suffering from? So for diagnosis, think of his symptoms. So symptoms are polyuria, polydipsia, non-healing ulcer, as well as look at his lab results. Now let answer the questions. So your first question is, what is your diagnosis? So diagnosis is diabetes mellitus. Yes, you are right. So diabetes mellitus occurs due to two reasons. It occurs due to an absolute lack of insulin, that is in type 1, or insulin resistance in peripheral tissues like skeletal muscles and adipose tissue, which is type 2. So let's understand the mechanism why it happens. So GLUT4 transporters fail to respond to insulin, preventing glucose from entering cells and leading to hyperglycemia. So think of insulin that it acts as a key, and if the key is missing or the lock, which is GLUT4 transporter, is broken, so glucose cannot enter the cell. Because cells feel starved, the liver works overtime making new glucose, that is gluconeogenesis, and stops storing it, that is decreased glycogenesis, and it causes blood glucose levels to spike. So in diabetes, cells cannot assess glucose due to missing or ineffective insulin. So body tricks itself into thinking it's a starving and switches to fat burning mode. So insulin normally acts as a stop sign for fat breakdown. Without effective insulin, the body continuously breaks down triglycerides stored in adipose tissues. So this releases free fatty acids and glycerol into the bloodstream to be used as emergency fuel. So the liver takes up the excessive free fatty acids produced during lipolysis. The liver breaks these fatty acids down via beta oxidation into acetyl-CoA. So liver converts the excess acetyl-CoA into ketone bodies. So these ketones are released into the blood to feed energy-hungry organs like the brain and the muscles. So let's understand in easy language. So insulin was a key. Since insulin isn't unlocking cells to let glucose in, the body starts breaking down fat stores, that is lipolysis. So liver converts those fats into backup emergency fuel called ketones, that is ketogenesis. So in severe insulin lack, ketones build up and make the blood acidic, though our patient today still tested negative for ketones. So moving to our next question, what are American Diabetic Association, that is ADA, and WHO guidelines for diagnosing the diabetes? So the answer is values are same for ADA as well as WHO. So fasting plasma glucose for both is more than 126 milligram per deciliter. 2 hours plasma glucose after 75 gram oral glucose tolerance test is more than 200 milligram per deciliter. HbA1c should be more than 6.5%, and random plasma glucose should be more than 200 milligram per deciliter plus classical symptoms or hyperglycemic crisis. So we follow only the ADA criteria according to Harrison also. So ADA specifically defines fasting as at least 8 hours without caloric intake. Now let's understand the important part about the confirmation of the diabetes. So if the patient does not have unequivocal hyperglycemia, means no symptoms, one abnormal result is not enough for diagnosis. So ADA 2026 recommends two abnormal results. Either the same test repeated on another day, or two different tests that are abnormal. For example, HbA1c is more than 6.5% plus fasting plasma glucose is more than 126 milligram per deciliter. So there is one exception if there are classic symptoms such as polyuria, polydipsia, unexplained weight loss, or hyperglycemic crisis. A random plasma glucose of more than 200 milligram per deciliter can establish the diagnosis. Now let's move to third question. What are the criteria currently adopted to diagnose diabetes mellitus? So diagnostic criteria is HbA1c should be more than 6.5%. Fasting plasma glucose should be more than 126 milligram per deciliter. 2 hours oral glucose tolerance test should be more than 200 milligram per deciliter, or exception case, that is random, more than 200 milligram per deciliter plus there should be symptoms like polyuria, polyphagia and polydipsia. Now moving to fourth question. So in addition to blood glucose and HbA1c, what other investigation would you like to do in this patient? So the answer is urine test for glucose, ketones and proteins. So we will check urine to see for extra glucose or the tiny amount of proteins, that is microalbumin. Protein in the urine is an early warning sign that diabetes is starting to damage the kidneys, that is nephropathy. So next we will look for lipid profile, that is total cholesterol, LDL is the bad cholesterol, HDL good cholesterol and triglycerides. So diabetic patients are high risk for dyslipidemias and this will clog the arteries and lead to heart attack. Next we will look for kidney function tests. So it includes serum creatinine, eGFR and blood electrolytes. Next, we will look for complication screening, that is fundus examination. So we have to look at the back of the eye for micro vessel damage, that is diabetic retinopathy. Then we will check for UACR, that is urine albumin creatinine ratio, and eGFR, which will assess the progression of kidney damage. Then we will check for nerve loss or poor blood flow in the legs and feet in case of neuropathy or peripheral vascular disease. Then we will check homocysteine and lipoprotein A. These are the blood markers to measure cardiovascular risk. Then we will do the special tests. So these are serum insulin and C-peptide. So they measure how much insulin the patient's pancreas is naturally making. Next are the autoantibodies. These are GAD, IA2, ZNT8. So these three are autoantibodies tested in blood work to diagnose type 1 diabetes and LADA. LADA is latent autoimmune diabetes in adult. So when a person has autoimmune diabetes, their immune system accidentally attacks the insulin producing beta cells in the pancreas. So GAD is glutamic acid decarboxylase autoantibody. So this autoantibody target against GAD, which is an enzyme in pancreatic beta cells. So it is a most common and sensitive marker for autoimmune diabetes in adults. So if positive, it strongly points towards type 1 diabetes or LADA, LADA rather than type 2. So next is IA2, that is islet antigen 2 autoantibodies, which targets the specific protein inside the insulin secreting granules of beta cells. So presence of IA2 indicates ongoing aggressive destruction of pancreatic beta cells and is common in children and young adults presenting with rapid onset type 1 diabetes. Next is ZNT8, that is zinc transporter 8 autoantibodies that targets the zinc transporter protein which help package and store insulin inside pancreatic cells. So if GAD and IA2 test comes back negative or uncertain, testing for ZNT8 helps confirm a type 1 diabetic. So patients of type 1 and type 2 present similarly, but treatment is completely different. So you have to confirm for LADA. Some adults initially look like they have type 2 diabetes, but positive autoantibodies show their pancreas is actually undergoing autoimmune destruction. So moving to our next question, what is the reason behind polyphagia and polyuria in this condition? So in diabetes mellitus, due to lack of insulin, glucose is not adequately metabolized and it fails to produce required ATP. Patient thus constantly feels hungry, and that is the reason behind polyphagia. Now moving to polyuria. So in diabetes, there is osmotic diuresis. So as a result, due to increased excretion of glucose in the urine, which also drags water along with it, it leads to excessive thirst. That loss from polyuria triggers intense thirst as the body attempts to restore hydration. So moving towards our next question. So what is the line of treatment? Patient should be advised oral hypoglycemic treatment along with dietary advice and physical exercise to enhance insulin sensitivity. Frequent monitoring of blood glucose is to be done, and anti-diabetic medication dose should be adjusted accordingly. So moving towards our next question, what is HbA1c? What is the most common method of HbA1c estimation? So HbA1c is known as glycosylated hemoglobin. So HbA1c reflects the average blood glucose levels over 10 to 12 weeks, over 3 months, right? So it is formed due to non-enzymatic combination of glucose with amino terminal group of beta chain of hemoglobin. Initially, the aldehyde group of glucose forms a shift base linkage with amino group, which then is spontaneously changed to more stable amino ketone linkage. So this reaction is known as Amadori's rearrangement. So unit of HbA1c, which is percentage, as it is the percentage of total hemoglobin which is undergoing such glycosylation. So concentration of HbA1c depend upon status of glucose in blood and duration of hyperglycemia. So values of more than 6.5% is diagnostic criteria of diabetes mellitus. So assessment of level of HbA1c is important for diagnosis of diabetes mellitus and also to interpret effectiveness and compliance to diabetic treatment. So moving to our last question. So name short-term and long-term complications of diabetes mellitus. So answer is, so diabetes mellitus is a metabolic disease characterized not only by its impact on various metabolic pathways, but also it is prone for developing various complications. So short-term complications like hypoglycemia, there is diabetic ketoacidosis, there is hyperosmolar, hyperosmotic coma, and then in long-term complication we have microvascular complication as well as macrovascular. So in case of microvascular, it is retinopathy and nephropathy. Retinopathy is diabetes is the most common cause of blindness. So nephropathy is also microvascular. It is a chronic kidney disease. Neuropathy is also microvascular, that is numbness, pain in extremities, foot ulceration. So retinopathy, nephropathy, neuropathy, these are microvascular complications. So in macrovascular complication, it is cardiovascular disease. Patient can present with myocardial infarction, then foot gangrene. It also present with macrovascular complication. Then other is gastroparesis, that is delayed stomach emptying. It's a diabetic autonomic neuropathy. Then patient is more prone to infections. So that's all for today, and do subscribe my channel for other case histories. Thank you.